Wow, good afternoon everybody. And I can already see a few familiar faces, so some of you have been to see me in the stand today. So I'm one of two lead immunisation nurse specialists, so my colleague Laura is here as well today, and she's doing a session just after this as well, if you're particularly interested. So thank you first of all to Sue for the introduction, and thank you on behalf of the UK HSA for the opportunity to speak to you today to the Midwifery and Maternity Forum. There's a lot of attitudinal research have been done amongst pregnant women, and they consistently shows that midwives and other healthcare professionals are the trusted source of information about immunisation in pregnancy, and rightly so, because you should be, shouldn't you? That's your area of expertise. You are experts in pregnancy, and I know that the immunisation side of it, from what some of you have said as you've been to the stand, is, you know, it's a difficult thing to get hold of. It's another thing that you have to do, but it is a really, really important topic. There's a huge body of research, so all we can really do today in half an hour is a bit of an overview. So really focusing on why we need to vaccinate, because of the impact of those diseases, and the impact and the safety aspects of the vaccination, because that's a really key part of the conversations that you have with the women in your care. And that's really why I'm here, to try and help support you with that really important role that you perform. I've also, I think Sue asked, and I'm very happy to oblige, to include something about measles, because clearly we're starting to see cases of measles, so we are going to touch on that as well. But other than that, I'm really not going to be describing the diseases or really going into detail about the schedules, because obviously we don't have the time to do that today. But there are lots of links throughout the presentation, and I believe you get a copy of that as well. And at the end, there are lots of slides with resources on. And if you haven't already done so, we are here till I think the man's coming to dismantle our stand at about 3:30. So we are still here if you want to come and visit us on the stand and ask us any questions, or as I say, go and visit my colleague's session in room A. Okay, so why we vaccinate? Well, I think we do tend to put these into some categories. They're potentially a little bit arbitrary, and we'll see that in a bit. But obviously, we mostly want to make sure that both the mother and the baby are safe throughout the pregnancy. So we prevent maternal morbidity and mortality. And obviously, pregnant women have changes both in terms of their immunological changes and cardiorespiratory changes in pregnancy, which put them at increased risk of severe disease from some of the pathogens while they're pregnant. We also want to prevent poor pregnancy and fetal outcomes, so miscarriage and premature delivery, low birth weight, congenital abnormalities and intrauterine death. And we want to confer passive immunity to prevent disease during infancy. So neonates and young infants are obviously particularly susceptible to infectious diseases, because their immune system is still developing during those first few weeks. So the transplacental transfer of maternal antibodies is a really important source of protection for them. So just to really illustrate that, I think, you know, although we tend to put these things into different categories like that, it's important to also think that most vaccines are going to work in more than one way. And I think this is a really good example of that. Looking at seasonal flu. So influenza infection in pregnancy can be really quite devastating. It increases the risks of maternal morbidity, because again they get more severe disease, they're more likely to be hospitalised, they're more likely to end up in an intensive care unit, and mortality, and that's especially in late pregnancy when those cardiovascular changes are at their greatest. The risks are higher in those women who've got additional risk factors, so if they're obese or they're diabetic, for example. And in the most recent Embrace report, which has been fairly recently published, 2 women died from influenza A during the period 2019 to 21 in the UK and Ireland. Neither woman had been vaccinated, and it is a vaccine-preventable disease. And the other thing, obviously, is we get poor pregnancy outcomes if people get flu during pregnancy. So you can get miscarriage and premature labour and low birth weight are all associated with influenza infection. And children under 6 months have the highest rate of GP consultations and hospitalisations for flu in the UK. So we don't tend to think of that. We tend to think it's an older person's disease, maybe. But these children are obviously naive in terms of their immunity. So vaccinating mum also helps to protect that newborn baby. We know that flu vaccination in pregnancy is incredibly effective. It halves the risk of infection with confirmed flu in pregnant women. It reduces the risk of prematurity by 72% during the period of widespread influenza activity. By widespread, I mean at the peak of the activity that in our hemisphere is in the winter, and of low gestational weight by 69%. They're fairly huge figures, aren't they? It provides passive neonatal immunity for the first few months of life. Lots and lots of research about this. 63% lower risk of lab-confirmed influenza among infants. And some of my own colleagues have done quite a lot of studies on this and found a significant reduction in fever, respiratory illness, and confirmed flu in babies born to immunised mothers. So it's always a concern. I know that there's a real issue around the safety issue. And, I was a midwife. It is a long time ago because I'm quite old. But there's been such a sea change in that time, really. And obviously, it particularly started with the flu pandemic in 2009. Before then, we weren't, routinely vaccinating pregnant women. But obviously, in my day, as a midwife, you had to really think hard before you gave people a paracetamol, and you certainly were very careful about giving, any other medicines in pregnancy. And so it's actually quite a difficult, transition to start to think differently about this. But obviously, in the interim period, we have masses and massive information, knowledge now about how the immune system works, how vaccines work, and how things are therefore safe. So, in 2009, when we did start vaccinating pregnant women, and we saw so many women with, being admitted for ECMO and dying from the pandemic flu, obviously at that point, huge amounts of work started to be done in terms of follow-up studies. Some of the vaccines in pregnancy are probably one of the most studied vaccines ever, actually, just because of all the, the additional concerns around both the mother and the baby. A review of a number of studies that was undertaken in 2009 concluded that no study to date had demonstrated an increased risk of either maternal complications or untoward fetal outcomes associated with an activated flu vaccination, and that it can be safely and effectively administered during any trimester of pregnancy. Well, of course, that's now quite some time ago, 2009, so you can't think, well, what's happened since? Well, I say continuous research and studies all of the time. They're very, very carefully looked at. And a more recent systematic review of 40 studies. So it's a hugely powerful piece of research, really, because they looked at over 100,000 pregnancies, confirmed the safety of the inactivated influenza vaccine, found that it was not at all associated with increased risk of being small for gestational age, or with congenital abnormalities or fetal death, and it was protective against preterm birth and low birth weight. But we are in trouble, really, because we're starting to see a real decrease in the amount of women who are taking up the offer of flu vaccination in pregnancy. So on the left-hand side of the screen there, you can see the uptake at its highest ever point, bearing in mind we started in 2009 and carried on, was 47.1% of pregnant women were vaccinated in 2017-18. Last year, at the end of the season, that figure was 35%. So we've already gone down 12.1 percentage points in that period of time. The most recent figures that we've got are on the right-hand side of the screen. Of necessity, data is always a little bit time-lagged, so the published data at the moment is only up to the end of December. So the end of December, in 2022-23, we had got to 33.2% uptake, which then the final one at the end of February, as the last collection, had reached 35%. But you can already see that we're only at 30.9 this year, so we're already behind on that. So we're not likely to make 35% this year. And I hope I'm wrong, because there's still time to go. The flu season, actually, in terms of being able to vaccinate, still runs till the end of March, and obviously we are seeing flu activity at the moment. So there's still time to vaccinate, and obviously we hope that more women will come forward during the interim period. And unfortunately in London, and you probably hear this a lot if you from this part of the world, but the figures are always worse in London, and I know there's huge issues that make that so, but you're only looking at 25.6% so far of it. So only a quarter of all the pregnant women in London have had their vaccine this year. And I think the other little point at the bottom there is that it's not just about percentages. Obviously, that's how we present data. We talk about percentages. But, if you've reduced the percentage of people that have been vaccinated, that for last year, that was another 26,500 people that didn't get vaccinated. These are individuals and their babies. So moving on to whooping cough. Now, I think this is one where I think we tend to think very much that this is a vaccine that protects the baby, and that's often the narrative that you hear, and certainly I think that's perhaps the message that women receive and feel more positive about it because it protects their baby rather than themselves. But of course it protects everybody, it protects the mother too if she has the vaccine. But clearly the main focus of this programme is to protect the baby because we know that pertussis really severely affects infants and young children during those first few weeks of life before they can be vaccinated themselves. They don't get their first vaccine until 8 weeks, and they get another vaccine at 12 weeks and then at 16 weeks, and then you really need 3 vaccines to give them full protection. So we know that they're more likely to develop the severe complications if they have whooping cough. They can have excessive vomiting, which leads to weight loss. They can have pneumonia, episodic apnea, seizures, encephalitis, and longer-term consequences, therefore, such as brain damage. And 90% of infants require hospital treatment. In a typical year, it's a sort of cyclical disease, so you get peaks and troughs. A pattern which has obviously been interrupted by COVID, but we're now seeing it come back again. We're starting to see an increase in cases again, which at this moment in time is within what you'd expect to see. It's not excessive, but it's obviously a disease that we've not seen for some time because of the COVID and the effects of social distancing. In a typical year, you would get 5 to 8 infant deaths from whooping cough. And then we had this really peak year in 2012, and there were 14 infant deaths that year. And it was at that point it was decided to introduce the programme. And as I say, although you know that's the focus of this programme, clearly pertussis can affect anyone. It's generally mild, but it's really quite troublesome. I mean, you can cough for 100 days. It's not pleasant. So clearly, if you give the vaccine to mum, you're also protecting mum as well. And I'm guessing, you know, mum really wants to have whooping cough while she's pregnant because it's horrible. So this one is actually just showing what happened, what happens in terms of the deaths. So we can see that, the cases. So the cases, onset of cases in children is very much skewed towards the left-hand side of the screen there. So these are the infants who are too young to be immunised. They are at a huge risk at that point. This is where the cases occur. And as you can see, that as we introduce the doses, the more doses they have, the less disease you get because they're starting to be protected against their own by their own vaccination. And this was the picture before we introduced maternal vaccination. So obviously this is why we decided to do something about this, because we were seeing these babies who were really ill, and the next one I think shows how many of those babies were dying. And the babies that were dying, the colours on here, it just represent the age groups. So the darker colours are from 3 months, less than 3 months. And you can see that the youngest babies are those who are most particularly being affected and dying because they've not yet had their vaccination or their full vaccination course. And as I say, we saw this huge peak in 2012, and then we introduced vaccination. And since then, you can see that the picture is absolutely different. And we are still, unfortunately, seeing some infant deaths due to pertussis. Those babies were all born to mothers who either had not been vaccinated at all or who'd been vaccinated too late for her to have made a sufficient response and for those antibodies to have transferred across the placenta to protect that baby. So vaccination during pregnancy gives approximately 90% protection against pertussis disease and 97% protection against death from pertussis in those first 2 months of life. So that's a huge statistic. Unfortunately, and it's not published yet, so it's not on the slide, at the tail end of last year in December 23, we saw another infant death in a child whose mother had not been vaccinated against pertussis. So, oops, sorry, not too far. So again, we're always concerned about the safety, so the vaccines that we give in pregnancy, this actually is a study, a systematic review, again done by some colleagues of mine, looking at studies from multiple countries. But we did start, as soon as we implemented that programme, we started a really tight programme of safety monitoring. So the first piece of published research there is from Donegan et al. In 2014, and that's the MHRA. So they were monitoring these vaccines from the outset, extensively monitoring these vaccines from the outset, and found no evidence of increased risk of any of a very extensive list of predefined adverse events related to pregnancy that they checked against. So both these two vaccines, so tetanus, diphtheria and pertussis, and tetanus, diphtheria, pertussis and polio vaccines, and it's the latter that we use at the moment in this country with the polio component. They've got really very reassuring safety profiles. And as I say, my colleagues did this systematic review, 16 studies from multiple countries, mostly in Europe and North America. So that's looking at, again, a large number of pregnancies, more than 150,000, using all of the vaccines available at the time and looking at a wide range of maternal, fetal and infant outcomes. And found very consistent findings and no concerns about safety with any of these vaccines. So, you know, the risks are similar whether you've been vaccinated or not. So clearly the vaccine is not making any of those outcomes more likely at all. So this is the latest figure, and it was only published, was it last week? Was it 2020? Yeah, 1st of February. There you go. We're hot off the press. Because I had my slides ready and then had to update them because it was hot off the press. But this is the absolute latest pertussis vaccine uptake in pregnancy data. And again, there's always a bit of a time lag, so we aren't looking at data that's beyond September last year for last year's data. So this is the monthly pertussis vaccination coverage in pregnant women in England from 2016 to 23. And it shows a 13.6 decline in coverage compared to the peak coverage, which was in the same reporting quarter in 2016-17. This is largely driven by a decrease in London, but is reflected in other regions. So it's not just, you know, it's not just happening here. It's dipped everywhere. We're seeing particular dips in uptake in the northwest and the Midlands as well. The bottom line then is the lightest line at the bottom. It's quite a nice colour, that, isn't it? But that is the rather sorry picture showing how few women are now undertaking vaccination against pertussis. And I think that's quite interesting because I think one of the things that we kind of always thought was because of the perception that this is a vaccine that protects my baby, I'll have that one. I'm not saying this is, you know, true as anecdotally, but I think there is that sort of perception out there that, you know, perhaps women were more inclined to take this vaccine, but are now not having this one either. And we certainly have seen some diminishment of uptake across the whole range of vaccines since the pandemic. And obviously there are concerns about increased vaccine hesitancy and some of the negative attitudes to vaccination that we're also hearing that have been perpetuated during the pandemic as well. And this is just looking at this from a regional point of view. So, unfortunately, the line at the bottom there, the dotted line at the bottom, is London. And again, obviously, the uptake in London is outpaced by the uptake everywhere else. But no one is seeing anything other than a decrease. But in this region, there has been a really steep decline. So it was 56.7% in June 2019. And we're down to 37.2 for June 2023, so 19.5 percentage points of drop. And again, I must emphasise we're talking about percentages, but these are people and their babies. So this is one little piece of information just to put in here about pertussis, because there are changes coming. So in the studies that I showed you that my colleagues had done, where they'd looked at all of those studies, they had looked at both vaccines that contained polio and vaccines that were without polio, and we are actually switching to the vaccine without polio in later this year. The JCVI, who provides advice to government about vaccination policy, reviewed the results of multi-centre randomised immunisation of mums against pertussis studies called IMAP studies. And in the first one and in the second one, and consistent with other international findings, they did find that there was a lower antibody response to the polio antigen in infants whose mothers had received a polio-containing pertussis vaccine during pregnancy, and that was true at both 13 months and before and after the preschool booster at 40 months. So it's what we call a blunting effect. Although the levels of antibodies in every case were above the protective threshold, and there's no evidence at all that this is clinically significant, you know, not seeing cases of polio in these children, nevertheless, once we have the opportunity to switch to something that's not going to cause that effect, and generally we try and give as few antigens as we can anyway to everybody who needs a vaccine, we're going to switch. And we were just really waiting for a product to have a licence to be used in the UK and for it to also be available at a cost-effective price. And that's where we're at now. So we're going to start using Adacel from sometime in this summer. So there'll be a period of time where you may have both vaccines in the fridges in the clinics. We'll be running down the supply of the other one and the Boostrix IPV, and then switching to Adacel. So COVID-19 is the other main thing that we are vaccinating pregnancy against at the moment. So we started here with one of the huge effects of COVID-19 infection on pregnant women is mortality. So in the latest Embrace report, 78 women died of a primary infective cause. 45 of those women died from a pneumonitis due to COVID-19. And of those, 27 were eligible and could have received 2 doses of vaccine. Now, obviously, there's a period where we weren't vaccinating, so some of those women were in that earlier period. But once we started to vaccinate, 27 women died of a vaccine-preventable disease. So the comments from there is that they had sometimes been offered and had received pertussis or flu vaccines, but had either declined the COVID vaccine, or there was no documentation that it had even been discussed with them. And only one woman who died from COVID-19 pneumonitis had received any vaccine, but she'd had her dose in the month before she died, too late for it to have had the effect that it needed to protect her. And she'd asked about having that vaccine several times during her pregnancy. There's another little piece on there that I'll come back to because I've got it on another slide as well. So, as well as the mortality figures, which are pretty chilling, it has to be said, they obviously pregnant and recently pregnant women with COVID-19 are more likely to be admitted to intensive care, need ventilation or ECMO compared to non-pregnant women of reproductive age. And as with all these things, there are a range of other factors as well which increase that risk, additional risk. There's a higher than background rate of stillbirth amongst infected women and an increased risk of preterm birth in women with symptomatic COVID-19. And again, it's because to produce maternal oxygenation, because clearly it's a respiratory disease, and there's often a requirement to deliver early. Sorry. And this is a really nice slide taken from. This is actually a graphic taken from a paper that was in the BMJ. I've blown it up so much that I hope the pregnancy still looks like normal, but I think she's okay. But I think, again, sort of on the right side of the screen particularly, we know that COVID vaccines are most effective, not so much at preventing transmission of the disease, but in all age groups, in all cohorts that receive it, not just pregnant women. We know that its best effect is reducing the amount of moderate to severe disease, and in reducing, ICU admissions. So they're really quite stark, these graphics. I think they show it really nicely here, because the green is the people who've had 3 doses, and you can see that the numbers there for them compared to the people who've had no vaccine, which is the rather nice pink shade, is considerably different. There's a definite sort of downward trend as people get more vaccines into them. So it is a very effective vaccine. This systematic review and meta-analysis looked at 81,000 women vaccinated in pregnancy and 255,000 unvaccinated pregnant women. So again, powerful numbers. 54% lower risk of maternal COVID-19 infection, 27% lower risk of intrauterine fetal death, and a 12% lower risk of NICU admission. And that same study, so again, remember, very huge numbers involved there, also looked at the safety and found no statistically significant association with preterm birth, small for gestational age or low APGAR score. It wasn't associated with increased risk of caesarean delivery, postpartum hemorrhage or chorioamnionitis. 2 other studies, large studies in the USA and Norway, which included more than 15,000 women, found that the occurrence of miscarriage was equally likely amongst unvaccinated women as well as amongst those who had been vaccinated. So, it doesn't cause miscarriage. The last one at the bottom compared live birth outcomes of vaccinated and unvaccinated pregnant women and found no differences in the rates of preterm births, neonatal hospitalisation, birth defects or mortality. But you won't be too surprised to find that the COVID is unfortunately also starting to go down. So again, this is very recent data published on the 25th of January. So we haven't got a lot of data there for 23, 24, but that is the data that's in blue, and you can quite clearly see a massive difference in terms of uptake of COVID-19 vaccination compared to the same period in the previous year. So hopefully it will start, when we get more data, it will start to rise and fall as last year's did, but we're tracking at a lower level. We're not probably going to reach anything like the numbers that we did before. And again, there are other things that impact on this, other inequalities, deprivation, black ethnicity, and being very young are other factors that make women less likely to be vaccinated. So just going to go briefly back to the Embrace study. So one of the things that the Embrace study did say was that around COVID-19 there had been quite confused messaging due to a lack of research evidence. And as a consequence, there was widespread vaccine hesitancy amongst clinicians and pregnant and postpartum women. And these deaths are evidence of those consequences. And it was not clear that there are plans in place to prevent similar issues occurring in the future. So I think what we're taking from that really is that one of the things that we're probably doing a disservice to pregnant women, and in fact all women of childbearing age, is that because of our historical and understandable concern about safety, we don't do trials in pregnant women. So, in childbearing age women, because of the risks of them being pregnant, and then, people are very, very cautious. And you can understand that, but that means we have very little data about any drug that we give to women of childbearing age, whether they're pregnant or otherwise. So the message now, I think, is that we're moving away from that, and we're actually going to have to see a bit of a sea change about this and start treating pregnant women and recently pregnant women and breastfeed women as the same as non-pregnant women, unless there's a very clear reason not to, and actually start encouraging the use of, putting studies and trials in place, including them in medicine and vaccine research, and making sure that we can get vaccinations programs for pregnant women started up a lot more quickly. There was obviously a bit of a time lag at the beginning of the whole COVID thing, where due to the cautiousness we didn't vaccinate pregnant women straight away, but we knew that pregnant women were obviously suffering really badly from COVID. So we can't be in that position again. So there's a lot of focus now on starting to vaccinate in pregnancy, increasing vaccination in pregnancy. Group B strep is, for example, is the focus of quite a lot of work and attention now. And another thing, which is respiratory syncytial virus, RSV, which I know from those of you who've been to the store today is not something this is not an entire surprise to you, but this is a one that's probably the next one in the pipeline, shall we say. So this is another winter respiratory illness which infects children in particular. It can cause infection in everybody. It also affects the elderly, and we're looking at a potential vaccine programme for them as well. But it infects about 90% of children under 2 years of age. And it's usually mild with cold-like symptoms, but for those people those children, it is not mild. It can cause really serious disease. And in particular in infants, you get bronchiolitis, and that's especially true of those very young infants who were born prematurely and have predisposing heart or lung conditions, or who are immunodeficient. And bronchiolitis is a really common cause of hospitalisation in children under 1. 1 to 3% of RSV-infected children go to hospital. There's 33,500 hospitalisations annually in children under the age of 5. So it's a really big problem. There is no cure, there's no treatment as such. It's all supportive treatment, so with fluids, oxygen, mechanical ventilation, and they often get secondary infections, so have antibiotics. And there's a mortality rate of about 3% in those very high-risk children, and about 20 to 30 deaths per year. So it is a big problem, and the solution is going to almost certainly be some kind of universal vaccination programme to protect neonates and infants. So there's this statement from the JCVI in 2023 And their recommendation is that we either have a seasonal with catch-up or year-round passive immunisation programme using a monoclonal antibody, so we give that to the newborn, or a seasonal or year-round maternal active immunisation programme, which would work like the pertussis one does now. So you give the vaccine to pregnant women at an appropriate time in their pregnancy. They make a response to the vaccine. They generate the antibodies that then cross the placenta to the baby and protect the baby in those first weeks of life. So lots of work going on behind the scenes, but one of the key things at the moment is looking at the cost of this, because all our vaccine programmes in this country have to be cost effective, not just effective. Clearly we're spending public money, so that's how it's looked at. So it's partly to do with the being able to procure the vaccines at a price that makes the programme cost effective. The JCVI suggested that it would be better to do this year round, because we're more likely to get high uptake. They've not expressed a preference for either approach, really. It really is down to looking at the logistics, looking at the cost, and looking at the operational thing. But I think we're probably going to get an answer on that in the summer. So that's coming. Right, measles, finally. Have I? Sorry, I'll whiz through these very quickly then. So, measles. We are seeing a rise in measles cases globally. That's happened since 2022. We saw a rise in England last year. We've now got an outbreak in the West Midlands, increasing activity in London, and cases are predominantly in those who are un or under-vaccinated. The vaccination rates, as with the others, fell globally during the pandemic, and the UK MMR coverage level has fallen to its lowest in a decade. It's a highly infectious disease, so you can pass it on with face-to-face contact of any length or more than 15 minutes in a small confined room. And in an if you had a completely unvaccinated population, one case could infect 90 other people, and 7 of those would have severe complications. But we know that two doses of MMR offers 99% protection, but of course we can't give it in pregnancy because it's a live vaccine. But why are we talking about it then? Well, because it still has an impact in pregnancy. It can lead to miscarriage, stillbirth, premature birth, or low birth weight. And pregnant women and infants, and in those who are immunocompromised, are at most risk of a whole long list of complications. And it has to be said, although that the mortality rate is not that high, you can still die from measles, and I think people forget that. But some of the other things that are in there, encephalitis and this late complication, the SSPE, that is a late thing that can actually happen many, many years after somebody's been infected with measles. So these are some key actions for maternity services, and I think this really does pull together some of the sort of more the context that we're starting to see around vaccination now. So obviously it's about protecting yourself so that you don't get measles and you can't pass it on. Checking the MMR status of all pregnant women and making sure that they're signposted post-delivery so that they're vaccinated as soon as possible after delivery. Clearly, you need to be conscious that if somebody presents with a rash, they could have measles, and so we need to be isolating them very quickly so that they don't pass that on. And we've got posters, we've got some examples out there of some public-facing resources that you can use to remind people of that. And obviously, also there's lots of guidance, and again, we've got a crib sheet about what to do if a pregnant woman is exposed to a suspected case of measles or has a rash illness in pregnancy. Unvaccinated pregnant contacts of a known case of measles, which could be, young infants, may require immunoglobulin. We certainly don't give vaccine until at least 6 months. Even in the case of an outbreak, you'd have to give immunoglobulin, and that is a blood product, so it's not something we give lightly. We'd rather not do that. So again, raising awareness, using the resources to encourage them to have their other contacts vaccinated, their household contacts, their other children, and making sure that you yourself are familiar with the local guidance and procedures. And one of the links there is a new set of slides which actually goes into the disease in a little bit more detail, just so that people are more familiar with the signs and symptoms, because lots of people have never seen it. Vaccination was very successful and not seen it, and then the guidance there as well. And I think that's it. Sorry, a little bit overrun. But the rest of the slides are all just resources for you to go and look at in your spare time. And I just put a few bits in there about the context as well that I think are very much to the fore these days. Thank you.